In this lecture, we will discuss the malignant tumors of the breast cancer. As you know, breast cancer is the most common type of malignancy among Iraqi women, accounting for about 30% of the registered female cancer. So, it is the most common type of cancer among Iraqi women. Now we have certain types of pre-malignant conditions and their relation with the cancer of breast. We have certain changes in the breast that are called fibrocystic change, and the relation of this change or this disease with the subsequent development of breast cancer. Certain types of lesions carries only minimal or no increased risk of breast carcinoma, and these include fibrosis, cystic change, apocrine metaplasia, and mild hyperplasia. All these carries no risk or only minimal risk for subsequent carcinoma of breast. We have some types of lesions that carries a slightly increased risk of breast cancer, which accounts for 1.5 to 2 times increased risk. These include moderate to florid hyperplasia, ductal papillomatosis, sclerosing adenosis. The lesions with a significantly increased risk of breast cancer include 5 times increased risk. These are atypical ductal or epithelial or lobular hyperplasia. If lobular hyperplasia or ductal hyperplasia associated with atypia, then there will be significant increased risk of malignant transformation. You know about the genes that involved in breast cancer, and we will pass to the diagnosis. Or just here I want to show you that association between HER2/neu gene mutation. HER2/neu is common clinical important driver of breast cancer, and its amplification lead to breast cancer. HER2 is a receptor tyrosine kinase that promotes cell proliferation and opposes apoptosis. It acts in a way it is a receptor tyrosine kinase. It increases cell proliferation, and increased cell proliferation can lead to a mutation in one point, and it acts as an anti-apoptosis. It stimulates RAS signaling pathway. RAS gene is most commonly mutated proto-oncogene by which the HER2/neu gene acts. And طبعا RAS gene present in about 30% of human neoplasms, and mutated RAS lead to cell proliferation and يعني continuous cell proliferation. Now the diagnosis of breast mass. When there is breast mass, we have a through pathological route for diagnosis. We here talk about definite methods for diagnosis. يعني بعيدا عن الراديولوجيcal and clinical. We have a laboratory test to diagnose breast cancer. We have 3 methods. First is open biopsy. Here we have either excisional or incisional biopsy, and it is done under general anesthesia. In incisional biopsy, the surgeon takes part of the tumor, and in excisional biopsy, all tumor is removed. Here this requires general anesthesia, and the results needs many days to diagnose because there is processing. Tissue core biopsy, true cut biopsy, and cytology. In cytology we have 2 methods, either fine needle aspiration when there is a mass, breast mass, or by nipple discharge. Let's start with the core needle biopsy. We call it a true cut biopsy. If we compare core needle biopsy with the cytology, with the fine needle aspiration, it is more traumatic procedure, and it require local anesthesia, while fine needle aspiration is not traumatic. It is not more painful than and not painful and not require anesthesia, and it is done in lab. It requires time and special equipment. It requires time because we will take a tissue, and this tissue needs processing and needs staining, so we have several days for the results, and it has a complication of the procedure, complication of the needle that is used. ممكن pain, discomfort or bleeding. Core needle biopsy هو gold standard for diagnosis for any palpable and non-palpable breast lesion, and it is favored over fine needle aspiration for the pre-operative diagnosis of breast carcinoma. Before in the last few years, fine needle aspiration كان هو يعني dependable تقريبا 100%، لكن in the last few years الcore needle biopsy تغلب عليه as in يعني a pre-operative diagnosis of breast carcinoma, and it permits definite diagnosis because in core needle biopsy we take a tissue and we can diagnose the lesion, while in fine needle aspiration we get cells, and this cannot give a definite diagnosis. The cytology, as we mentioned, we have two routes for obtaining the sample by cytology procedure. We have a nipple discharge if there is nipple discharge, and even nowadays nipple discharge becomes of less importance in use for diagnosis of breast carcinoma. Only when there is bloody nipple discharge we can do a cytologic examination, and the second procedure is by fine needle aspiration. Fine needle aspiration used for palpable mass, and if the mass is very small can be done under the guide of ultrasound. طبعا يعني هسه مثل ما ذكرنا احنا بدأ يقل استعمال الفاين نيدل اسبريشن. previously sensitivity كانوا يعتمدون عليها 87% specificity 100%, but now it is less dependable. هسه الجولد ستاندرد هو الكور نيدل بايوبسي. اكو multiple centers for يعني خلوها على مود screening program national health service breast cancer screening. اكو عندنا several centers حتى حتى موجودة بالعراق include هذا السنتر شنو بي surgeon و radiologist for doing ultrasound and mammography and pathologist على موديل fine needle aspiration. هذا السنتر شافوا انه من افتتحوا هاي السناتر قلت الريسك، هو سكرينينج بروجرام قلل الانسيدنس او الانسيدنس قل اوف بريست كانسر، وقلت البيشنت اللي يجون at advanced stage in stage 3 او stage 4 قل، صار الانسيدنس زايد بالايرلي ستيج اوف بريست كانسر. الادفانتج اوف fine needle aspiration انه هي easy, reliable, cost effective diagnostic technique which can give rapid results. ممكن خلال يعني 1 to 2 hours ننطي result. The procedure can be performed in an office setting without anesthesia. It is not more painful than venipuncture. At the disadvantage إنه it is not possible, disadvantage of fine needle aspiration, it is not possible to distinguish between Insitu and invasive carcinoma because we only get cells and we don't know whether these are invasive cells or Insitu carcinoma cells. This is breast carcinoma, fine needle aspiration. This is cytology specimen. We here see clusters of malignant epithelial cells with malignant features of the nuclei. They are large, hyperchromatic, pleomorphic, high NC ratio, and discohesive cells. We see there is loss of cohesion or adhesion between these cells. We call it discohesive cells. Now, histologic types of breast carcinoma. Generally, here we have two categories: non-invasive and invasive. Non-invasive, also called Insitu carcinoma of breast. We have two types: ductal carcinoma Insitu, here DCIS, and lobular carcinoma Insitu, here LCIS. Invasive carcinoma, we have many types. Invasive ductal carcinoma or infiltrative ductal carcinoma, which is the most common histologic type, and it accounts for about 70 to 80% of cases, followed by invasive lobular carcinoma, which accounts for 10 to 15% of cases. We have carcinoma with medullary features, which account for nearly 5% of cases. Mucinous carcinoma or colloid carcinoma accounts for about 5% of cases. Tubular carcinoma, which accounts for about 5% of cases, and other less common types, not common. Insitu carcinoma, as we mentioned here, by definition, Insitu is not penetrated the basement membrane of the breast, of the ducts of the breast. It is not beyond the basement membrane, while invasive, no, it has spread beyond the basement membrane. Ductal carcinoma Insitu, here we have as we mentioned, we have about Insitu, we have ductal carcinoma Insitu and lobular carcinoma Insitu. About the ductal carcinoma Insitu, we have 5 main types. We have cribriform carcinoma, comedocarcinoma, solid Insitu carcinoma, papillary Insitu carcinoma, and micropapillary carcinoma Insitu. Let's start with the comedocarcinoma. Here we have sheets of malignant pleomorphic cells. These cells, this is the duct. We have a proliferation of malignant epithelial cells, malignant mammary epithelial cells. Usually in comedocarcinoma, the cells show high-grade malignant features, and there is central area of necrosis. In the center, there is necrosis and surrounded by malignant cells of high-grade features with surrounding, or we call it periductal fibrosis and inflammation. This is periductal fibrosis, and here the inflammation. So we have necrosis, high-grade malignant features of the mammary epithelial cells, periductal fibrosis, and inflammation. This is comedocarcinoma, which is type of Insitu ductal carcinoma. Here we have central area of necrosis, which is surrounded by high-grade features, malignant mammary epithelial cells. This is the necrosis. Here also we have necrosis and high-grade malignant epithelial cells with periductal fibrosis and inflammation. The non-comedo DCIS, here we have cribriform carcinoma, and we have solid, papillary, and micropapillary. In cribriform carcinoma, we have here, for example, this duct show a proliferation of malignant cells, and there is spaces between these proliferated malignant cells. If we focus on these spaces, we see that these spaces are regular, and also the myoepithelial cells here are lost. The solid type, there is no necrosis in the center, and there is no cribriform or spaces between the tumor cells, but there is solid sheets of malignant epithelial cells. In papillary type DCIS, this grows into spaces. We have here the papillary structures with the central fibrovascular cells. We have multiple layers of malignant mammary epithelial cells, and there is loss of myoepithelial cells. Here the micropapillary, the protrusions of epithelial cells are towards to the intra ducts, towards the lumen of the duct, and in the center there might be a calcification or necrosis. So we have here papillary and we have here micropapillary. There is no fibrovascular core. There is only a papillary projection of papillary structures towards the lumen of the duct. Insitu lobular carcinoma. Insitu lobular, unlike DCIS, has a uniform cells. كل lobular carcinoma, whether insitu or infiltrative invasive lobular carcinoma, the tumor cells tend to be small and tend to be uniform or monomorphic in their appearance. They are round, their nuclei are round and forms discohesive clusters. Tendency for being bilateral is high in these types of tumor. They can involve the other breast. Here we have expansion of the lobule by lobular carcinoma in situ. Here we have proliferation of uniform monomorphic small round tumor cells. This is lobular carcinoma in situ. Now we come to Paget disease of the nipple. Paget disease of the nipple, this name is given to a crusted lesion of the nipple that is caused by breast carcinoma. This disease is usually accompanied in 100% of cases by underlying breast carcinoma. Usually the type of this underlying breast carcinoma is Insitu ductal carcinoma, associated or not associated with stromal invasion, but definitely there is underlying Insitu ductal carcinoma with or without invasion. So Paget disease is only a secondary feature of the tumor. It is secondary feature of the tumor. It is involvement of a nipple. The nipple shows Paget cells. The Paget cells are large. This is a clinical feature for crusted lesion in the nipple, and the nipple is hyperemic. This is Paget disease of the nipple. The hallmark of Paget disease is the presence of Paget cells. Here we have, this is the nipple, and here we have large cells with large hyperchromatic pleomorphic nuclei and surrounded by a perinuclear halo. This is called Paget cells. Paget disease is not in skin invasion, is not nipple invasion by mammary ductal carcinoma, but we have theories by which these Paget cells are seen and associated with underlying Insitu carcinoma, but it is not an infiltrative lesion. It is a clinical manifestation of underlying disease, and Paget disease does not worsen the prognosis of breast carcinoma because it is not regarded, as we mentioned, as invasion of the skin by underlying carcinoma, but it is an association for association for underlying disease, which is Insitu ductal carcinoma with or without invasion. It cannot worsen the prognosis, but actually it can make the prognosis better because it can brings the patient at an early stage because there is a crustation and hyperemia of the nipple. Invasive carcinoma of breast, we have invasive ductal carcinoma. Here we'll discuss the invasive ductal carcinoma, which is the most common type of breast cancer. It accounts for about 70 to 80%. Grossly, this is the typical gross picture of infiltrative ductal carcinoma. We have white, firm consistency, irregular mass infiltrating the breast tissue, and poor circumscription. Rarely it can be soft and well circumscribed. Here we have a grating sound or grating sensation during cutting. It's characteristic for this lesion because of presence of elastotic stroma and excessive fibrous tissue and sclerotic lesion. Fibrous tissue formation and calcification can give the grating sensation during cutting. Microscopically اكو variation, there is variation in the microscopic features of invasive ductal carcinoma, وهذا يعني variable from according to the grade and differentiation of the tumor cells. In grading of infiltrative ductal carcinoma, we depend on degree of tubule formation. كل ما كانت well formed tubules مثل هنا tubules well formed with a central lumen, كل ما كان well differentiated. بينما بال poorly differentiated أو high grade lesions, there will be scattered discohesive cells with no or only little tubules formation. The nuclei increase in the size of the nuclei and irregularity of their nuclear membrane يودينا باتجاه high grade. Mitotic figure, كل ما كانت atypical mitosis more numerous and high in number, this will increase the grade of the tumor. Also proliferative rate, كل ما كانت high rate of proliferation, كل ما كان poorly differentiated or high grade tumor. And the tumor necrosis, presence of tumor necrosis will raise the grade of the tumor, and we will go towards the high grade or poorly differentiated tumor. Invasive lobular carcinoma. An invasive lobular carcinoma is the second most common type of breast cancer. Here it can form a palpable mass, and characteristically this tumor also irregular white color with which is not well circumscribed. Here we have biallelic loss of expression of CDH1, which encodes E-cadherin due to its mutation. Invasive lobular carcinoma morphologically اكو فد specific pattern for diagnosis of infiltrative lobular carcinoma. احنا previously we mentioned that most tumor cells are small and monomorphic, round, and the pleomorphism is only minimum in this type of tumor. We have a specific pattern for this tumor, which is called Indian file appearance, that the tumor cells arranged one beyond the other, similar to the Indian file. So it is called Indian file appearance, and the dysplasia or the fibrosis is minimum, not like infiltrative ductal carcinoma. The dysplasia is minimum here. Sometimes we see signature formation or small loose clusters of sheets are common in this type of tumor, or mucin signaturing or mucin formation can be seen commonly in this tumor. Carcinoma with medullary features, it accounts for about 5%, as we mentioned, and it tends to be to form a round mass, and sometimes this is a movable mass, so it can give hint that this tumor is benign because it is round, and because it's well circumscription, and because of its mobility during the clinical examination. Generally, this tumor carries favorable prognosis, and germline mutation, BRCA1 mutation, frequently seen in this type of breast cancer. Microscopically, medullary carcinoma shows the characteristic feature, which are syncytial sheets of cells, and these cells carries high features of malignancies. These are pleomorphic hyperchromatic cells with prominent nucleoli. These sheets are surrounded by stroma, which contain large number of inflammatory cells, and predominantly T lymphocytes and plasma cells are seen in the tumor. Colloid mucinous carcinoma commonly tends to occur in postmenopausal women, and one of the soft breast cancer they tend to give soft consistency، ولذلك تنطي انطباع انه هي ممكن تكون benign because it's soft consistency, and they tend to be well circumscribed with gelatinous cut section. Microscopically, these tumors are rich in mucin. These are the mucin and these are the tumor cells. This is the mucinous carcinoma or colloid carcinoma of breast. Tubular carcinoma. In tubular carcinoma, we have tubules formation with a characteristic feature of this tumor. It tends to be small and tends to be multicentric. Also, it's one of the favorable type in its prognosis. They carries excellent prognosis. Inflammatory carcinoma. Inflammatory carcinoma, this name comes from a clinical appearance of this type of carcinoma. They tend to be clinically erythematous, and the breast becomes enlarged and swollen, similar to inflammatory condition, and clinically there is no palpable mass. Microscopically, the underlying carcinoma is no specific type, and the true inflammation is only minimal or absent. يعني تشبه not otherwise specified اللي هي tumor cells, sheets of malignant tumor cells without inflammation. This tumor carries aggressive behavior and poor prognosis. Thank you.